perspectives, I want you to be familiar with the family of coronavirus and how SARS-CoV-2, which is the name of the virus that results in the disease COVID-19, compare, understand the factors that are driving the epidemiology and challenges related to community spread of the disease. And I will introduce some basic epidemiologic principles as well, starting off. The clinical presentation of COVID, I will show you 3 papers that describe the patient population and the symptoms. And then we will touch quickly on the current process and procedures here at HHS. So coronavirus, the name comes from how they look like with those crowns that you see on the surface. The Latin word for crown is corona. It's called 1960 in chickens. It's an envelope virus, single-stranded RNA. There are 4 genera. Relevant to humans are alpha and beta, with the source being bats. There's also gamma and delta coronavirus, which at least to date haven't resulted in infections. As I mentioned, alpha and beta, bats, they are from bats. They need an intermediate host, typically, where further recombination happens and mutation events to eventually transmit to human beings. This is a busy slide showing you the 7 coronaviruses. 4 are here are the common coronaviruses. There's 4 strains here. You don't need to remember the names of those. They are with us for thousands of years, probably spread worldwide. Origin, bats, intermediate host unknown. Human-to-human transmission through droplet and contact transmission. We have millions of cases each year. Mortality probably 0%. They are around us year-round and peak in fall and winter. Then we had SARS, of course, 2002 in November, starting in Guangdong province in southern China. Again, bats, civet cats were identified as the intermediate host. Same transmission, roughly 8,000 cases, 774 deaths, so mortality rate of 10%. It disappeared 2003. 87% of cases were in China and Hong Kong. MERS-CoV occurred in 2012. Bats, again, the source, dromedary camels as the intermediate host. What we see with MERS is limited spread within humans, so it's from your camel to a patient, a cluster of people around that person through human-to-human transmission, but the chain of transmission stops because it doesn't easily transmit between humans. 2,500 cases, 861 deaths, so a fatality rate of roughly 1/3. And the number of cases are declining significantly since 2016, and 80% of cases were in Saudi Arabia. COVID-19, as you all know, identified in December 2019 in Wuhan, Hubei province. The pangolin, I have a picture here, it was thought to be the intermediate host. I think it hasn't been confirmed yet, whether that's the case or not, doesn't really matter at this point of time. But there was an initial transmission from either a pangolin on that market or any other live animal. What's happening now is human-to-human transmission. Sequencing studies showing probably a single introduction of one virus into the human population. The virus has 79% similarity with SARS. That's why it's referred to as SARS-CoV-2 as well. It uses the same cell receptor, AC2 in humans, and it has more than 96% homology to that coronavirus. Some basic epidemiology, and it's just one single slide, but everyone has read about R0, or what we say, the term we use is R0. So talking about the impact of a novel virus, it's a function of R0, and I will talk more about details, the effectiveness of containment or mitigation strategies, and of course the viruses or the diseases, morbidity and mortality. Now, R0 itself is a function of the infectious period. So, of course, the longer someone is infectious, the longest period of time that that person can transmit to someone else. And this would include transmission during an asymptomatic or pre-symptomatic period. And I will show you some studies on that. The contact rate, the more contacts you have, the more likely you are to transmit. And that's why social distancing is also currently recommended. Then, of course, the attack rate. So if you have contacts with someone, what's the probability that it transmits? And this is in itself a function of the mode of transmission. So if this was airborne, and I was standing here and I had it and I would be coughing, you probably would all, many of you would get it. Given that it's proper contact, I wouldn't infect anyone in here, even if I was sick. And then the population immunity. By definition, the R0 assumes no immunity, which is true for this virus. When you see an R0 for flu, for seasonal flu, it's not really an R0 because we have a baseline immunity against the virus. Effectiveness of containment and mitigation strategies. This is from a tool. I have the link down here from David Fishman from Toronto, where you can play around with if you can reduce the transmission by or the R0 by 20%, 40%, how your epidemic curve look like. So obviously, the more you can reduce transmission, the flatter will be your peak, but typically the longer will be your epidemic locally. And morbidity and mortality I will talk about. In the meantime, probably everyone knows where Wuhan is, roughly 11 million people living there, 7th largest city in China, the capital of Hubei province, which has a total of 60 million people living there. This is in a nutshell what happened, just as a reminder. So end of December here, pneumonia cases were found to be linked to Yunnan seafood wholesale market in Wuhan. A few days later, an outbreak was announced. The market was closed. WHO was notified early January. Outbreak of the novel coronavirus as the pathogen was announced that was January 9. PCR diagnostic reagents were available widely January 11th after the China CDC publicly shared the gene sequence the day before. So it took a little bit more than a week to have the virus identified and sequenced. The first confirmed case from Wuhan reported outside of China was only a few days later in Thailand on January the 12th, and it was January 19th when the first case outside of Wuhan on mainland China was identified. In the beginning, as you can see here, 55% of cases were linked to the seafood market. After that, only 8.6% cases linked. In the meantime, we are presumably at 0% because the human-to-human transmission just evolved. Study on early transmission that was published mid-January that included 425 patients, showed a median age of 59 years, predominantly males, a mean incubation period of 5.2 days, R0 of 2.2, and the mean serial interval of 7.5. Mean serial interval is you have an infected index case until you see the infection in the next group of people infected by that index case. And with those 7.5 days, I try to show that here with the yellow circles. So roughly every week, you see, at least in the beginning, roughly doubling of the numbers of cases, which would be aligned with the R0 in the range of 2. There's a lot of modeling studies out there, and I will show you only a couple. This was an interesting paper from, I believe, late January. They not only did forecasting, they also did nowcasting. So try to figure out how many people are there really infected with this pathogen. Their assumptions were on all of 2.68, 0 interval 6.4. They nowcasted that there must be 75,000 people infected in Wuhan by January 25th, 2020, based on their models, versus at that point of time, 2,000 confirmed cases. In terms of forecasting, and that's the curves you see here on the left-hand side, you can see that for several cities, for several cities, that the peaks were expected to be very close together. Now, it didn't really play out this exact way, but what I want to show you here is that if you can reduce the transmissibility, which is your middle figure on top, you can reduce that peak very significantly, and that's very important when we talk about strategies later on. By reducing mobility, that's the lower curves there, doesn't make a huge difference. That was the epidemiology in February 14th, 2020 from the Johns Hopkins side. That's when I first worked on a presentation on coronavirus. And this is how it looks March 10. Not many more red dots, but when you look just at the numbers, we had an increase from 64,000 to 116,000. That was per 2 days ago. In the meantime, I believe we're on the 130,000. That was the status internationally on February the 14th. We had 7 cases in Canada, 50 in the US, no cases in Central and South America, no cases in Africa. I need to say no confirmed cases. Africa at that point of time had two testing centers available. There were only 3 cases in India, no cases in Pakistan. The main concern outside of China was Singapore back then, with 67 cases. And that's how it looks now. You're all familiar with uncontrolled transmission, basically in Europe. The same applies to the US. Also, they don't want to believe that yet. Canada, I would say, we still have more or less control, but it gets more challenging, and that will be the other piece in my presentation today. This again was asked for 2 days ago, so it doesn't include our case and a couple of other cases that occurred since. 1 death in BC, 32 cases there, 36 in Ontario, and a couple of cases in Quebec and 7 in Alberta back then. Just one note here. Modeling studies are suggesting that probably onset was mid-November, but it took a while until there was a critical number of people infected, so people started to realize that there's a new disease out there. And that's why it was only detected and shared in December 2019. I skip to this slide here, which shows you the timeline. The red bar showing you the number of new cases per day. And you can see here, that's when it was mostly contained to China. It seemed that it was dropping around February 10th, so mid-February. We saw a decrease, and I think that was the last time that there was hope that maybe this can be contained. But what you now see again, here at the end of the curve, an increase in number of cases, and these are mostly international cases, so not Chinese cases. And of course, I want to talk about, that's just a different way to plot it, the orange line here showing you the case in mainland China, and there was that 1 day where they added 15,000 cases. That was because they changed the definition in Wuhan, because they were not able to test a significant number of patients, or all the patients that they thought may have it. So they said, let's add clinical assessment and CT findings as also confirmed cases, despite the fact that the virus wasn't detected. So that added 15,000 cases that day. When you're looking at this, at the curves here, again on top, mainland China, and the yellow curve being outside of China, you can see that the epidemic, or since yesterday I can say the pandemic officially changed mid-February, where you see the cases in China dropping off. So there was only smaller numbers of cases each day, but it really started outside of China. Modeling studies more or less consistently suggest that we probably only see 1/5 to 1/10 of all cases out there. So we only see the tip of the iceberg. And this has major implications on outbreak control, obviously, because if you don't capture everyone, you will not be able to stop the chain of transmission. And it also makes interpretation of severity very challenging. So again, going back to February 14, and just to give you an idea how heterogeneous the numbers in terms of fatality rates are. Back then, overall fatality rate 2.15%, in the Hubei province 2.5%, outside of China 0.4%, only 2 deaths back then, one in Japan and one in the Philippines. If you do the same exercise now or 2 days ago, Wuhan is at 3.5%. Hubei province, the first was overall worldwide. Hubei province is at 4.4%. Outside of China, we are sitting at 2.7%. But when you're looking at outside of China, and these are selected countries that have like the highest number of confirmed cases, and they added in Canada as well, you see that the fatality rate ranged from 5% in Italy to 0.5% in Switzerland. And there are several countries that have hundreds of cases, and at least 2 days ago, they had 0 deaths. That was Sweden, Belgium, Norway, and Singapore. Why is that? It's not a different virus, right? It's not so much different patient population. The healthcare systems aren't that different that they would explain such huge differences. I guess what's happening is in Italy, we only know the tip of the iceberg. There's a lot of community transmission. We only capture a small fraction of everyone who has it. You capture those that get sick, the ones who die. So they are all represented, and you have an inflated fatality rate. And we probably have more reliable case finding in Canada and the other countries listed at the bottom here. And just as an example, and I don't want to mention the US too often, but one of the issues here is by February 26, the US tested 445 patients. Given the population they have, that's a ridiculously small number. March 10, that's when I checked the numbers in Ontario. Only in Ontario, we have tested 2,747 patients back then. And that's only 2 weeks later. So we are much more aggressive in terms of testing from the very onset. Now, how does COVID-19 compare? Now you're all experts with R0, which is here at the bottom from 0 to 7, and the case fatality rate from 0.01 to 100%. And you see it sits somewhere between seasonal flu, SARS, and Spanish flu, so the 1918 influenza pandemic. So fatality rate probably somewhere in the range of 1 to 2%. We don't really know it yet. And the R0 probably somewhere between 2 and 3. Okay, let's talk about clinical presentation. And again, it's still in the bad section of my talk. We start very bad here. That was the first case report, single-center cohort at one of the Wuhan hospitals, 138 consecutive admissions. And I would say, well, probably the other piece here is they had hospital-associated transmissions in 7, or assumed transmissions in 57 patients. That was almost half of the patient population. And they defined hospital-associated as a cluster in the same board as a possible index case. And 40 of those were health professionals, so 20% of all individuals. So health professionals clearly overrepresented in this cohort. And there were only 17 patients with hospital-acquired infection. I don't have time to go through all the details here. What I would like to highlight is 17%, 12.3% needed invasive mechanical ventilation at all 138 patients had changes in the CT with patchy shadows, ground glass opacities. And of course, lots of comorbidities. In terms of symptoms, almost all patients had fevers. And when I show you the other case series, you see it really depends on your patient population, how reliable fever is. Here it was super reliable with 98.6% having a fever. And then you have fatigue, dry cough, all the ARI symptoms you would expect with flu or any other respiratory virus. What this study highlighted was that there were 14 patients, so 10% of all patients who presented initially with diarrhea and nausea before they developed fever and shortness of breath. And one of these patients was admitted to a surgical ward and was presumably responsible for 14 transmission, which you could consider a super spreader event, which you typically saw with SARS. Beyond that, concerned with COVID yet in terms of super spreader events, it seems to be a rare event, but here it certainly happened because that patient wasn't isolated and was cared for in the surgical ward, and they probably didn't think that the patient had a respiratory infection. Some better news here outside of Wuhan, that was 62 cases in the Zhejiang province, mid-January to end of January. Median age here was younger, 41 years. Onset of symptoms to admission 2 days, so they presented very early. I didn't highlight that in the first study. In Wuhan, patients typically presented to the hospital after 6 to 7 days. Fever in 77% of patients, expectoration 56%, headaches, myalgia, fatigue. Few patients with diarrhea. Only 2 patients out of those 62 developed shortness of breath. Only 1 needed ICU admission and no death. And then a study in between in terms of severity, a larger cohort across China for cases that occurred in January, again, median age 47 years. The composite of ICU, mechanical ventilation, and death occurred in 6.1%. Fatality rate in this cohort 1.4%. Only half of the patients had a fever upon initial presentation, but up to 90% developed the fever later on. 2 out of 3 patients coughed. Only a few patients again had diarrhea. And I keep talking about diarrhea because some people suggest that we should consider this as one of the hallmark symptoms. Probably that's not the case and was skewed by this first study for an unknown reason. Only half had changes in the CT, so obviously a less sick patient population than in the first study I showed you. What I would like to highlight here is lymphocytopenia seems to be very common, maybe 3% of patients here. And then the last one, that's more like a high-level report from the China CDC. All 72,000 cases until February 11, 44,000 of which were lab confirmed, so other searches based on take assessment and CT findings. The majority were in the age range of 30 to 69, so everyone who's listening today here. 81% mild cases, 14% were severe disease, so this is the patient population that clearly will need hospital admission, and 5% had critical disease and needed ICU admission. Fatality rate here 2.3%. Among the population who was older than 80, it was 14.8%. Among healthcare workers, 0.3%. Okay, let's switch gears and talk about transmission from asymptomatic patients. This was the first report from Germany that suggested transmission from asymptomatic carriers. So the index patient from China visited Germany, a couple of business meetings here, flew back to China, developed symptoms after that, and days later was tested positive in China. That index patient had contact with patient 1 and 2, attended the same business meeting, and those patients, those German patients, developed symptoms a few days later, so 4 to 5 days later, were tested positive, were the first important cases into Germany. The assumption was that the patient was entirely asymptomatic, so the index patient was entirely asymptomatic at those business meetings, and this was published here in the New England Journal of Medicine. A few days later, the Robert Koch Institute, which is like the CDC counterpart in Germany, got a hold on that index patient, and as you see there on the first line, they got the information from the index patient that she was already symptomatic during those business meetings. She took the Advil and was going through those business meetings to the best she could, and then flew home. So it wasn't asymptomatic transmission. This being said, patient 3 and 4 entirely unclear what happened, and I will not talk about it. But a couple of more here. So again, patient 1 is your index patient, entirely asymptomatic, never developed symptoms. And then you have a patient 2 and 3 that had contact between January 10 and January 13, and then developed symptoms later in the month within the 14-day range that we currently assume. And the only reasonable link was for all those patients, 2, 3, and also the other patients, contact with that index patient who came in from Wuhan. And that Wuhan patient was tested positive later on in the absence of symptoms. So again, suggesting transmission from an asymptomatic carrier. And then the last one of those I'm showing you here, patient 2 and 3 were from Wuhan. They traveled to Shanghai and lived there with patients 1 and 4. We are here between January 15th and January 20 and 20, they lived together. Patient 1 developed symptoms on the 20th. Patient 2, so the patient who probably brought it, developed symptoms on the same day, then eventually they were admitted, patient 1 died. So again, suggesting that patients 2 and 3 were incubating and the transmission occurred while those patients were incubated before they developed the symptoms. So that was the bad. Couple of ugly slides here. The main concern we have with any novel virus is once we are losing the chain of transmission. As long as we know, okay, this patient has it because it's imported from wherever, Hawaii, then we can cast a net around this individual, trying to identify anyone who may get or was potentially exposed and may develop disease, isolate them, etc., and stop the chain of transmission. Once we lost that capability, we will see community spread, and that's what's likely happening in the US. Now, on the left part, you have this PDAC conference. I believe they had 25,000 participants there in Toronto. And the first case related to this was identified in Sudbury a couple of days ago with no other contacts whatsoever. So it seems very convincing that probably the patient has it from that conference. Now, when you have a conference of 25,000 people, there's at least one more person there who had it, who was the source, but probably many more who will develop the disease. And this is a situation where we already lost a chain of transmission, and we can only hope that we can get it back at some point. And then, of course, our own case a couple of days ago, the physician, you probably all read about it, who worked on Monday afternoon, developed the symptoms, got tested very quickly, and then was identified positive after that. So here, we still have the chain of transmission under control, but locally, of course, it's on the ugly and not on the bad. And that's why we all look like this. But finally, now that we had the first case in Hamilton, the WHO agreed that it's a pandemic. So they were probably waiting for us to have the first case. So again, since yesterday, we are officially in a pandemic. Also, fact is, we are in a pandemic for weeks already. Okay, one more slide on the outbreak. That's, I would say, plausible with a question mark worst case scenario. So the CDC estimates that 8% of people contract seasonal flu every year. So in Canada, among 37 million Canadians, that's roughly 3 million individuals getting the seasonal flu. But we have no vaccine, we have no immunity against this virus, and we have a higher R0. So you can put any number in there and multiply those 3 million by something. 5 is a plausible estimate, I would say. Most epidemiologists expect that if you let it just go without any mitigation strategies, somewhere between 30 and 70% of your population will get infected before the transmission stops, because there's not enough susceptible people anymore. And with this, you end up in the 40% range. That would be 15 million infected in Canada, resulting in roughly 2 million excess hospital admissions, 440,000 excess ICU admissions, and estimate using a 1% attributable mortality, 150,000 excess fatalities. So that would be a 52% increase in death. Now again, this is like a worst case scenario if we just stop doing anything. And the other piece is nobody knows over which time period that would occur. If you break that down to Hamilton and say you have a catchment of 2.3 million, you would expect that roughly 1 million gets infected, 150,000 hospital admissions, 30,000 ICU admissions, at least theoretically, 10,000 deaths. And now we need some good. Yeah, working on it. Most likely it's not going to play out this way. We are in good shape, at least so far. We have more time to prepare than other countries had. And we may dodge the bullet. I doubt it that we will fully dodge it, but there's certainly things we can do or things that can help us to be better off. So warmer temperature, well, some people say, yeah, we just need to wait for summer and it will disappear. Probably not. There's at least a chance that it may not transmit as easily anymore, like most coronavirus do. But we need to see, there's many countries that are much warmer these days and see transmission, so it's not that it will just stop, but maybe easier to control. And then the mitigation strategies, and we'll talk about this on the next slide. Once we have lost the chain of transmission, so currently we are in a containment model, so we try to contain any transmission. Mitigation strategies are the point of time where we lost the chain of transmission, you're unable to contain it or to stop the spread, but you can slow it down and reduce the impact. And what you're trying to do, and that's why I showed those two curves again, you try to reduce that peak so you don't have, like here, an estimated 40 in 1,000 patient population developing the symptoms each day or the disease each day, to maybe 20 or only 10, which will widen your peak. So you will have sick people over a prolonged period of time, but that's much more easy to handle also from a healthcare system perspective than if you have within a few weeks a very large number of patients who need medical care. And I think when you're looking at those numbers here, again, that's from 2 days ago, you see China, 80,000 cases, but only 2 more cases. So if we assume that their case finding is still working relatively, relatively reliable, I would say, they probably don't control it, seems. Not sure whether that's true, it's China, and we may see the truth in a few weeks, but at least based on what's reported, you can be optimistic that with very drastic strategies, you can actually stop that. Italy, on the other hand, is the bad news. They were back then at 9,000 cases and added 1,800 cases on March 10th and another 100 deaths. South Korea, which is testing very aggressively, is slowing down as well. They were at 7,500 confirmed cases and only 130 new cases. Iran, again, different topic there. I think we only see a very small tip of the iceberg there, so I wouldn't do too much of that. Let's talk about containment and mitigation strategies and well, treatment options. There's an awful lot I can talk about at this point. So from a public health perspective, and this is really a public health challenge and less of like SARS, a hospital transmission challenge. What we are currently doing is self-isolation. So whoever's at highest risk has to self-isolate. Who's at the lower level of risk needs to self-monitor. And that has been working well so far for Canada. What's happening is reducing travel. People make their own choices to reduce the travel. Others, in other areas, it may be opposed to people not to travel. We have travel notices, we have flight suspensions to Italy, for example. Then entry bans, and you probably heard about the US now banning any travel from Europe for the next month. And again, I feel like they are still in denial mode. They are probably as bad hit as Europe. They have uncontrolled community transmission. It's too late to shut down. You have it in your own country. You have to deal with what you have in terms of person-to-person transmission. But that's just my 2 cents. Staying home when ill, hand washing, cough etiquette, something that we already need to do. We are always supposed to do, but it's more a mitigation strategy. So once you have local transmission, that's something we all have to do. We have to do social distancing, and we already started today by implementing that. And that's what you see across Europe with cancelling sport events, conferences, etc., avoiding those large mass gatherings of people. And again, that's not a containment strategy. That's once you assume there's transmission out there, we have lost the chain of transmission, but we can reduce further spread or at least slow it down. Vaccine, in January, we were told it takes 12 months. Now we are in March, we are still told it takes 12 months. So it's not going to save us with this pandemic, not at this point of time. This being said, we don't know what's going to happen with this virus, right? Will it be one of our common coronaviruses moving forward? How do we respond the second time we get infected? If this comes back every winter, maybe because of the immunity, it's just one of those common colds, maybe not, and maybe we need the vaccine at this point of time. We can only hypothesize at this point of time how this will look like. And again, masks are not recommended outside of healthcare or when you're caring for infected patients. You are all well aware of that. We have shortages worldwide when it comes to PPE, and we don't want to waste those valuable resources by wearing them outside. There is no evidence whatsoever that it will prevent you from getting infected. In the healthcare setting, what we do mostly is early identification and screening, making sure that no people come in without being identified as at risk for having it to prevent the transmission from happening. Now, as I showed you in terms of potential transmission in the pre-symptomatic phase or even for asymptomatic people, even this will not shut it down, right? Because you will have people coming in who may be infected, are incubating, may already transmit it. And this, of course, applies to the public health measures as well. These are the people you wouldn't isolate and can continue to spread this. Then in terms of PPE, we are still, like the US and Quebec, in a really N95 mask mode. That may change. All the other provinces and territories would recommend just what PHAC, our feds, recommend, which is a surgical mask. But for now, we are doing N95. gowns, gloves, face shield. Don't forget the face shield, please. Much more important than you wear an N95 or surgical mask for patient care. In terms of treatments, there's clinical trials in China. We hope that we get some results earlier rather than later. Remdesivir is like a broad spectrum antiviral. That's like the carbapenem in the antiviral world, which has promising data. Lopinavir, ritonavir, one of our old HIV drugs, Kaletra, plus minus interferon is something else that's being trialed. Chloroquine has some data, and people are even using our flu treatments, mifenovir and oseltamivir, with no biologic plausibility though, but some people believe it may help. And ACE inhibitors is another at least theoretical approach because it's the AC receptors, right? So maybe if you block them, it may there may be some benefit. And it's not only treatment that's of interest, it would also be prophylaxis. So if you can use any of those drugs or like a ring prophylaxis, what people did with Ebola, where you vaccinate the ring around index cases, that's something that may work, we just don't know at this point. And otherwise, yeah, just trust Trump, there will be a miracle and it will just disappear. That's my last slide on this list. What's the current situation? So from a public health perspective, it's self-isolation if traveled to the Hubei province or Iran within the last 14 days. Now the process apparently to add Italy, or at least northern Italy, to this like highest risk group. If you have any other travel to a risk area, it's self-monitoring. So measuring your temperature twice a day, and once you develop any respiratory symptoms, stay at home and contact public health. In the healthcare setting, as I mentioned, we screen for and test very broadly in the meantime. The provincial recommendation is still based on a few countries that you would need to test. We implemented Friday to test everyone with any travel, and that was mostly driven by the cases that got imported from the US last week. And without that change, we wouldn't have identified that individual for Monday, right? Hawaii. At that point of time, there was 1 or 2 confirmed cases in Hawaii. Who would have thought about someone importing coronavirus from Hawaii? But it happened, and based on our new criteria since Friday, we tested the individual and we identified the pathogen. And then PPE, I talked about. As I said, in Ontario, it's still spreading airborne as well. In other provinces, it doesn't. HHS, we have testing available in all of our EDs and the urgent care center at this point. We are working on an assessment center with public health and CHOS and other key stakeholders to increase our testing volume without blocking our EDs. And I think Barry will talk about the IMS, the incident management system that was implemented this week, and how we operationalize the work around COVID-19 these days. These are just 2 screenshots from the email that went out yesterday about travel, that we now want everyone who's traveling abroad to inform employee health before they do so and when they come back. And depending on the potential risk at that point of time, decisions will be made how to handle the situation. And the main issue is travel. You can plan a trip now for April to Antarctica, for example, which looks pretty safe these days, probably still safe in a few weeks, but things may change, right? Or you may end up in trouble going there because you're coming from a high-risk, relative high-risk country with several cases in Toronto. So it may have implications there, or may have implications once you come back if anything happens during the time you're there. So it's very unpredictable these days, and worst case scenario, you will end up in self-isolation. I doubt that Canada would close the borders and would not allow you to come back, but self-isolation may So these were my slides, Barry. Do you want to add anything?
Yeah, just a few words. Thanks very much, Dominic. It's nice to see the the science and the rational thinking. Just a few comments because we do want to have a few minutes for questions. For those of you on Zoom, you can actually send in your questions and we'll try to answer them. So from a IMS point of view, HHS has been working with public health, the province, and so on, literally for 10 days or more to try to get ready for this. The IMS system was activated and we have had very frequent and regular meetings. The situation at the JCC arose Monday evening, and I think you can tell that there's been an incredible amount of work done to deal with that particular scenario. I think we need to think about this in two distinct processes. One is we have a situation at the JCC which is under control and needs to be managed, and we will need to work very hard to support the patients and the staff in the JCC situation, and there will be ongoing meetings and discussions about that literally hour to hour. The other relates to the big picture of COVID in the community and the unequivocal likelihood that we will have more cases, and we need to be very vigilant about how we're going to respond to that. And so the IMS system, working with public health and so on, will also be going on simultaneously. So we will be very busy. Dominant's picture of the person with the dark circles and bloodshot eyes, I think, are pretty well guaranteed for many going forward. So we'll start taking questions now.
So I'll ask the questions if that's okay.
Yeah, fire.
I think, I'm just testing, I think you can actually hear me because I'm so loud. So first question is, will we be switching from droplet to aerosol precautions?
Assume the question is vice versa. Will we switch from airborne to droplet precautions? Currently, we have patients in airborne, droplet, and contact precautions, so we are using the N95 mask, which again is the precautionary principle that we applied early in Ontario, mostly based on the SARS hit this province got back when SARS came over. We know much more about the virus in the meantime, and everything we have out there in terms of evidence suggests that it's contact and it's not airborne. So we hope that we can change sooner rather than later from airborne to only droplet contact, which is how all our viruses transmit, all the coronavirus transmit. There's no evidence that N95 masks add anything in terms of protection. So we will, as soon as we get the guidance to do so from public health.
Thank you. Maybe I'll ask, I've got the OTN mic now too, so I apologize if there's feedback for a second. Are there any OTN questions from St. Joe's?
Yeah, question about the testing. We have NPS pending for COVID on a patient. We got the regular NPS back within 24 hours, but COVID is not back. Why is that? Why is it taking longer? And how is the testing done? What are the properties of the testing? Very, very reliable or not so much? Thanks, John.
So the reason for the delay is that the testing for COVID is at the public health lab. It was moved from the Toronto Public Health Lab to the Hamilton Public Health Lab last week, which took people a number of times. But yeah, it's not an in-house test, right? It needs to be transported to public health. By Monday, that's the last estimates I heard from our lab, we will be up and running with our own lab, and we will see the same turnaround times that we see for all our other viruses. So our multiplex PCR for flu and the other viruses will eventually include COVID, so you will routinely get that test in addition to it. In terms of sensitivity, specificity, I guess that was your question. There were some concerns when you remember the London case, which first tested false negative, it seems, and then the National Microbiology Lab identified the patient as being positive. I think in the meantime, as far as I know, there's no sensitivity concerns as long as the sample is well obtained, and I think that's always the sampling error may always be an issue. But the PCR itself, I'm not aware of any major concerns about sensitivity or specificity at this point of time. This being said, it's a gold standard, so it's very hard to compare it to something else.
Questions from, any more questions from St. Joe's?
Can I add some more information about the lab, just so people are aware? Can you hear me? It's Wes Stevens. The federal government announced yesterday $1 billion. Some of that is to enhance testing. Both organizations, St. Joseph's and Hamilton Health Sciences, are moving forward in procurement of more capital equipment for the lab and for operational dollars to actually do these tests. So the provincial government has signaled to all the academic labs to start investing and to ramp up testing. So you've heard already in the presentation that we are doing a fair bit of testing, but the goal is to put it back into regional areas, academic labs, to actually be able to ramp up. Modeling is being done at the lab to look at a significant increase of lab testing and turnarounds. So both organizations have committed as of yesterday to move forward. Hopefully in the next few weeks we will be able to really ramp up. Just so people know, behind the scenes the labs have been doing testing of the local tests and they're running on a few panels. So we're not starting at zero, but we just need approval of the government to actually run it. The federal government and the government are putting knowledge towards it, and we're hopeful that this is not going to be a rate clinical issue.
And maybe to add, I didn't mention that in addition to the targeted testing in patients that you deem to be at risk, there's a sentinel testing happening at many of the major sites. So Toronto, I think it's Hamilton, London, Kingston, all of at this point of time, they are sending up to 30 swabs, NPS swabs per day to the public health labs for testing for inpatients. So if you have an inpatient, you test that patient for flu, most likely it will be one of those 30 swabs and the patient will be tested. And that's part of that sentinel network that we currently have, just to make sure that we are not missing any community spread before we identify it. And so far, all of those tests were negative. So it really looks like we are still on top of things at this point, and there's no hidden clusters of people infected, at least not of those that need admission to the hospital with respiratory symptoms.
I'll just make a comment too from the lab perspective. You know, we're way ahead of the US in terms of lab testing for complicated regulatory reasons, which when you hear in the US that there's an absence of testing, that's a real problem. In Canada, I wouldn't anticipate that that's going to be a problem. Any questions from the McMaster side? I think my mic, no, ideally there shouldn't be anybody there, so we shouldn't get any response. From the web, one of the frequent questions here is, what's the definition of a large gathering, and should we be canceling large gatherings, however defined?
The easy answer is leave that to public health. They will make those calls sooner or later. As you know, we ended up canceling the internal medicine review course because it's a large gathering of hundreds of people, but at this point it's a judgment call, right? It's not that public health banned any of those, or not yet. What we see in Europe, the magical number was 1,000 for a long period of time, that they said nothing with more than 1,000 people would happen. Now some countries went down to 200 or even 100 and only allow a few exclusions to that. That's in the situation where you have value in a mitigation strategy, right? You know you have spread in the community, you lost your chain of transmission. Then these are the measures that can and should be put in place, I guess, and I wouldn't be surprised if sooner or later that this will happen here as well once we have local transmission, but this one we don't. but it's not the wrong thing to err on the side of caution with one or the other of those conferences and meetings, because there might be that one individual who's asymptomatic and just starts a community spread without anyone knowing, and the smaller the gatherings at that point of time, the less people will be affected.
So we've lost the OTN, but I think we still have Zoom. Mark, do you want to ask one more question or two?
Yeah, there's many questions, so I'll have to cut them off, but I think an important one is, what are the screening or monitoring recommendations for yourself if you end up being MRP providing care to a COVID-19 patient?
At the end of the day, it's the same that we're all supposed to do at any time, right? Whether you are caring for a patient who's known COVID positive or flu positive or whatever. Temperature, depending on the patient populations you look at, I show you the case series, fevers, only 50 to 60% initially, so don't just rely on the fever. Stay home if you have any respiratory viruses or symptoms of a respiratory virus, being it COVID or anything else at this point, because we cannot tell them apart, right? They typically present the exact same way. COVID is more likely to later on develop severe symptoms, and when you're looking at the case series, it looks like most people are doing relatively well in the first few days, and then rather of getting better, they are getting worse and worse and develop the ground glass changes in the CT and developing shortness of breath typically after 5 to 7 days only. So early onset, if you have symptoms of a respiratory virus, stay at home, but that's the same message that we have for years and years and years. Fevers isn't reliable, and I think that's the main challenge. You cannot say only stay home if you happen to have a fever in addition to respiratory virus. But again, regardless of whether you have contact with a confirmed case.
So there's many questions, so I apologize for those who don't get to them, but I'll ask one more, which is interesting. For those patients who are immunocompromised, but sort of electively, like people, for example, who are on immunosuppressive drugs for rheumatoid arthritis, should physicians be reducing the intensity of their immunosuppression now?
Yeah, that's an easy one. So the evidence clearly tells you to do X or Y. We don't know. I think at the end it's weighing the potential pros and cons in a situation like that. We don't have any evidence for the pros, but you have evidence what may have happened with the symptoms of this patient if you reduce the immunosuppressive therapy. So there's no straightforward answer. And whether reducing whatever the patient is on, or if you have a patient on chronic prednisone and you reduce the dose by half, whether that's of any benefit to the patient, nobody really knows. So I cannot provide a good answer to that at this point.
The last thing we would want to see is a patient reduce their dose of treatment for their inflammatory bowel disease, get sick, and get admitted to hospital.
Yeah.
So Barry, I'll turn it over to you. I think we should end it there. Sorry again for those who asked questions we didn't get to.
So thank you, Dominic, very much, and thank you everybody for attending both virtually and for the few people scattered in the audience. Stay tuned.